Today we will have a discussion on operative scenario. We have decided the topic today as laparoscopic cholecystectomy. Presenter today will be Dr. Shoham Bhomi. Shoham Samant, who is a first-year junior resident at MR Bangalore Hospital. So today our topic will be, so in the exam you got a card for operative steps. So obviously the operative step starts with the indications. So if I talk of laparoscopic cholecystectomy, what are the prime indications for cholecystectomy?
So the primary indication is any symptomatic gallstone disease,
Yes.
and there are a few other
Symptomatic gallstone disease
symptomatic,
includes number of conditions like
like chronic
cholecystitis.
chronic cholecystitis,
Yes.
mainly calculus cholecystitis,
Yes.
and
What are the other presentation? Patient has gallstone disease. Patient present chronic cholecystitis. Patient has the mucosal of the gallbladder. Patient can present acute cholecystitis. Acute cholecystitis in certain conditions. There are some contraindication for doing lab chole in acute cholecystitis, but most of the indications are now in favor of lab chole in acute cholecystitis. Then empyema gallbladder.
Polyp of the gallbladder more than
10 millimeter. More than 10 millimeter. Gallbladder polyp. Then symptomatic cholesterosis. Porcelain gallbladder. Okay. And what are the there are some contraindication for proceeding with lap cholecystectomy. Contraindication.
Acute cholecystectomy.
No, acute cholecystectomy is not that absolute contraindication. Absolute acute cholecystectomy in most of the time you are in favor of doing cholecystectomy. Absolute contraindication is malignancy of the gallbladder. When you are looking at patient with having carcinoma gallbladder, one should not proceed lap cholecystectomy. You have to proceed for radical cholecystectomy. Now people are doing even radical chole with laparoscopy, but as such, lap cholecystectomy as such is a situation where you should not proceed in a patient who has got a carcinoma of the gallbladder. Okay, cirrhosis gallbladder was a relative contraindication. Okay, fine. So you are for a lap cholecystectomy. What are the usual pre-op preparations? Is there any special pre-op preparation for a routine cholecystectomy vis-a-vis other major surgery? You have a general preparation for a major elective surgery. So for lap cholecystectomy, is there any special preparation? No. Just the patient who are not jaundiced, who does not have liver dysfunction. So in a routine lap cholecystectomy, the preparation is for a usual major elective surgery. You take a good history, other comorbid conditions. If there is a comorbidity, you correct that comorbidity. Okay. And then you do some basic investigations to assess the fitness for anesthesia surgery. So as such, there is no special preparation. But while you take consent for lap cholecystectomy, what is a specific thing you discuss with the patient?
The chances of being converted to open cholecystectomy.
So patient has a inclination for going for lap cholecystectomy, but there are some situations where lap procedure may not be feasible and he might need to convert to open procedure. So that consent has to be taken. So you have to explain the patient that we proceed for lap cholecystectomy, but without any difficulty, patient might need conversion to open cholecystectomy. So and then the other informed consent is always there. For any major surgery, you should take informed consent for any major surgery. But for lap cholecystectomy, a specific point to mention is there might be necessity for conversion to open cholecystectomy. Okay, fine. So you have decided patient in the theater, and now you describe the steps. When you describe the steps, you start with steps.
After proper dressing and dripping of the
Dr.
patient.
Ronit has asked a question. What are the indication for doing cholecystectomy in silent gallstone? We have talked
Yes.
of symptomatic gallstones, but there are some indications where you do cholecystectomy in silent gallstones.
So one of them is in case of thalassomic patients, those who undergo uh, splenectomy, we generally do prophylactic cholecystectomy.
Okay. I mean, a patient having thalassemia who are the indication for splenectomy and patient has gallstone disease, you should do. Most of the patient has symptomatic also in thalassemic patient. Well, fine. What else? Silent stones are what?
Mm,
How do you define silent gallstone?
without any
Patient
patient
needed to
doesn't
have
have any
gallstone and patient does not have any specific
specific
symptom to the
symptom of
gallstone disease. So these are, how do you detect silent gallstones?
uh, most of them are incidental findings.
One is patient has gone for a health checkup.
Health check.
Patient has gone for a health checkup and you detect this stone. Or patient has some other symptom and patient underwent a routine
Routine
ultrasound abdomen and you detect the stone.
ultrasound.
So this is how you detect silent gallstones. Okay. So when you why is not a routine recommendation that you do silent gallstone all patients who are under cholecystectomy? Why this is not done? Why is not a situation that you do consider lab colief in all patients of silent stones? Suppose 100 patient has gallstones. What percentage of patient are symptomatic? What do you think? Minority or majority? Symptomatic
Minor,
patients.
minor,
Minority. 70 to 80% patient of gallstone patient are asymptomatic. So it's a huge number. So you cannot uh, offer cholecystectomy in all patients with silent stones. Is a huge number of patients who has got silent stones. So is not a indication for doing lab chole in all patients. But there are some situations when you should consider doing lab cholecystectomy in these patients.
So,
Like
soldiers going to a war or
so patient
in acute situation,
in a situation that they cannot have a access to medical care in case
medical
of
care
emergency.
emergency.
Okay, that is one. Second, is there any correlation between the size of the stone and considering for lab cholecystectomy?
Yes, sir, but I
What?
don't remember the exact.
So it is said that you see, gallstone is one of the situation which is ascribed to be a cause for malignancy, although the incidence is not very high. Huh?
Yes,
So patient having a large stone more than
large
2.5 centimeter or 3 centimeter has higher incidence of carcinoma gallbladder. Okay,
yes,
young patient,
yeah.
young patient, because the what is the chance of these patients developing symptoms if you follow them over 5, 10, 15, 20 years? If you follow this patient up for the long period of time, why is the recommendation that you need not consider lab chole for all patients? Because you follow this patient up, the chance of developing symptoms are not very high. Okay, you say that 1% per year. That means at the end of 10 years, there is a chance for 10% patient developing symptoms. At the end of 20 years, 90 to 20% patient has reached level. So it's not very high number. But there are some situations where you have to consider. One, you said. Second is, one recommendation is that there is a high incidence of gallbladder cancer in Gangetic belts in northern and eastern part of India. So one of the recommendation is if the patient is living in an endemic area of carcinoma gallbladder, you can consider doing prophylactic cholecystectomy. Or patient has family history of gallbladder cancer or malignancy in the family. Okay. Earlier it was said that patient having diabetes or other conditions should consider, but now people are saying that the incidence of having a ferment cholesterol is not very high in diabetic also. Earlier diabetes was a relative indication for doing this. Okay.
Yes.
Okay. Now we are uh, in the actual steps. So if you divide the steps of laparoscopy, try to describe the. Now I will not disturb you. We will describe the steps, and then we will interrupt, and in between we may ask some questions. While describing the steps of any operation, try to divide the steps into salient headings and describe what you are doing in the particular step. So, what are the steps for lab cholecystectomy?
So after proper dressing and dripping, first step is to make the ports for the
So
operation.
once you
First,
start any operation, start with anesthesia. The first thing you do on table is anesthesia. So it's general anesthesia with individual intubation.
it is preferred for general anesthesia with
And
intubation.
next part is you describe the position of the patient.
Position of the
In
patient.
lap cholecystectomy, the position is
So it
is
reversed
initially
pendulum,
supine, and
initially
then
supine.
you change position
Then we
after a situation.
Yes.
So initially, patient should be supine position.
supine position.
Then antiseptic cleaning and dripping. This is same. These 4 points are they are in all operations. So start with that anesthesia, position of patient, antiseptic cleaning and dripping. Done. Now you start the actual operation. What is the first step in the operation?
First step is to make the umbilical port.
I told you, make a heading. The first step of the operation is induction of pneumoperitoneum.
Induction of pneumoperitoneum.
While you are doing lab pulsing, the first step in the operation is induction of pneumoperitoneum. So describe the steps of induction of pneumoperitoneum.
So for induction of pneumoperitoneum, we can go through the umbilical after making the umbilical port, or we can.
No, don't confuse. When you are describing in the uh, practical examination, you describe one particular technique. Now, if the examiner wants to know other techniques, they will ask you. You describe one particular technique, what you are doing in actual operation. And then if the examiner wants to know other steps, he will ask you. Okay. So you describe a particular technique of achieving a neoperitoneum during surgery. You describe.
We will make the umbilical port, preferably through.
It's not port fast. It's not fast.
Open.
It's not port fast. I asked you induction neoperitoneum. Yes. So keep on describing what you do exactly.
First, after making a smile incision, uh, preferably in the infraumbilical region, we place.
So we make a infraumbilical 1 centimeter sub.
1 centimeter
smiling
incision.
Then
and then after dissecting the uh, layers of that anterior abdominal wall, either with.
You don't dissect layers of abdominal wall. What is there? If you are in the subumbilical region in the midline, you don't dissect all the layers.
Not the layers.
What? You incise the skin and subcutaneous tissue. What is the next layer?
The fascia. And
what fascia? If you're in the subumbilical region, the midline, what is that structure?
The linear.
Linear bar.
Yes.
So why do you say layers of abdominal wall? Say linear bar.
Linear.
What do you do with that?
After dissecting the linear alba, once we reach the peritoneum, we place the varus needle at 45-degree angle, holding it in a dart holding position, and then first test for the placement of the varus needle.
How when you pass the needle, what is the direction of the needle? You are standing on the right or left of the patient?
On the left of the patient.
So you stand on the left of the patient. You have made a subumbilical incision, and then you can make a nick in the linea alba, and then pass the varus needle at what direction, at what angulation?
At 45 degrees.
Yes.
With the
in obese patient, you can go at right angle. Right. But in most of the patient, you make a 45 degree and pointing towards the pelvis. And as you go in, you have a specially designed needle, which is spring-loaded needle. Yes. So as you go in, you appreciate the click.
Click.
Okay. Usually there are two clicks. One click is when you go through the linea alba, and second when you go through the surgical peritoneum. Okay.
Yes.
So once you have two clicks, you are possibly inside the peritoneal cavity. Now is the time to confirm that you are in the peritoneal cavity. How do you confirm?
So first we insert 5 ml of normal saline through the Wells needle and then aspirate after a few seconds. If there is, if nothing is aspirated through the needle, we can, that's the first step. We can confirm that we are in the uh, inside the abdomen. Second is the drop.
Durable.
Second is the drop test. After putting a water drop, if you lift the abdomen, if the and that is the second step of confirmation. And the third step of confirmation is by insufflation. When we attach the air, the carbon dioxide source, and we are slowly we increase the flow rate by 1 to 2.
No, no. You look at the monitor. You look at the insufflator.
We look
There
at
you
the
look at,
insufflator.
and yes, you are saying that yes, I am in place. When?
If it initially it will be there will be negative pressure
It
and
may not be negative. Ejaculation is not always negative.
slowly it will increase,
It will
but
be less than 10.
less than 10. It will
Okay,
be
if
in
it
a
is
range
showing
of
high
10 to
pressure,
20. Yes, sir.
so the point I asked you, how do you confirm the needle in the peritoneal cavity?
Yes, sir.
The first is not putting saline. The first is aspirate.
Yes.
When you have placed the needle, nothing should come through the needle. You are in the blood vessel, blood will spurt out. You are in the bladder, urine may come out. Okay? The first step to confirm is aspirate. If in the peritoneal cavity, usually nothing should come, number one. So first is aspiration. Second is you inject 5 ml of saline and re-aspirate. Third, you say is drop test. And fourth is you attach the needle to the insufflating machine. The machine was set to 12 mm mercury with a flow rate of 3. The pressure in the machine now should show as 5 or 6, 7 or 8 or usually less than 10. Then you are certain you are in the peritoneal cavity and start insufflating. So this is the first step. You use a Veress needle, and this technique is described as a closed technique for achieving pneumoperitoneum. Fine. So you have inside a needle, confirm the needle is in place, and now attached to the machine, and you start insufflating. Initially insufflate at a low pressure. Why? Insufflate at a low flow rate and at a set pressure of 12 or 14. Why you insufflate slowly at the beginning? What is the ill effect of rapid insufflation?
Sudden stretching of the pneumoperitoneum
Yes.
can cause vagal stimulation.
Yes. What else? One is vagal stimulation, and second is more important is not only vagal stimulation. Patient is anesthetized. Even if there is some vagal stimulation, there may be some bradycardia. That is true. But what is more detrimental? If we insufflate very rapidly, what is going to happen? What happens in the abdominal pressure?
Burst up.
Not burst
No,
abdomen.
sorry, sir.
If you insufflate rapidly, there is rapid rise of internal pressure. That can cause sudden compression of the intra-vena cava.
Okay.
That can reduce the venous return, and patient may have development of sudden cardiac arrest. So this is very important. When you start insufflating, you should insufflate in a slow rate with a flow rate of 1 to 2 or 3 liter maximum, and then gradually insufflate. Rapid insufflation can cause rise of internal pressure rapidly, can cause compression of IVC, reduction in venous return to the heart, cardiac output may go down, and patient may have cardiac arrest. So one should not do rapid insufflation. So once you have set to pressure to 12 and you have achieved 12 milligram mercury pressure, the first step is done. Neoperitoneum induction is done. What is the next step?
Next step, we will now make the umbilical port.
So the next step is placement of first port.
First port.
What is the importance of placing the first port?
First port mainly is to visualize the peritoneum.
First port is a blind port.
Blind port.
You are doing closed neoperitoneum. So the first port is a blind port that has to be done with caution. Otherwise, there is risk of injury.
Yes.
Even if there is the risk of injury. Yes. Fine. Yes. So first port you is a take a 10 millimeter port, which is a 10 millimeter trocar and cannula. And how do you introduce that?
So there are 4 techniques.
Yeah. I told you practical examination. You describe one state technique. What 4 techniques? You are doing closed. Now technique is one only. Don't confuse. 4 techniques, different techniques of induction neoperitoneum. Yes. Once you have used a varus needle, abdomen is now insufflated to a desired pressure. Now you take a 10 millimeter port, okay, which has to be, there are some port with a safety device. Yes. Okay, that you can take. But now the port you are entering to is a blind port and you should enter with caution. Yes. And again, how do you describe this port entry?
Sir, I'll be doing open Hassan technique.
Open Hassan technique. Don't confuse. If you are doing a open Hassan technique, there is no question of using varus needle. Once you use a varus needle, you have already achieved neoperitoneum. Now is the time to use a blunt port. Okay, if you are choosing a open technique, then you will not use a varus needle. It's open from the beginning. So what you are trying to describe is a closed technique of neoperitoneum you have achieved by using varus needle, looking at all the points, looking at the insufflator and pressure. Now you take a 10 millimeter trocar and cannula, hold in your palm, and the movement is a gradual twisting movement. And again, make an angle of 45-degree pointing towards the pelvis. If it is an obese patient, you can go vertical at right angle. And you go gradually and see at one point there will be loss of resistance. And there will be hissing sound. Already carbon dioxide inside the peritoneal cavity. Once the cannula has gone to the peritoneal cavity, there will be hissing sound of escaping carbon dioxide. You know you are in the peritoneal cavity. Don't push further. Take the trocar out. The cannula is in. So the next step, as I said, first port entry is done. What is the next step?
Then we will place the camera to visualize.
What do you place actually? Don't place the camera inside the abdominal cavity. What do you place inside the abdominal cavity? Where is the camera?
The
camera is in the eye of the telescope. So now you have already prepared the telescope attached to the video camera and the light cable.
Yes, sir.
And you have already focused and see the monitor is on.
Yes.
Now is the time that you introduce the telescope attached to the video camera and the light source. And your picture in the monitor now. What is the first step? Once you are inside the peritoneal cavity, what you do first?
First, we examine the entire abdomen.
Before you go to the entire abdomen, the first thing you should mention is, once I go in, I will see the site of port entry. The place where you place the varus needle, place where you place the first port, you should look at that area. Any bleeding, any injury. Okay. So that is the first thing you do. And then once you have seen this, you make a bird eye view of the whole peritoneal cavity. Okay. Yes. Look at the peritoneal cavity. Try to look at the liver area. Try to look at the gallbladder area. Okay. And look for any other pathology in the abdominal cavity. Okay. So a inspection of the peritoneal cavity. Next step should be, once you have done this, what is the next step?
So the next step is to make the other ports.
Yes. So next step will be insertion of second, third, and fourth ports. Now tell me, where do you place these three ports and how do you do that?
So the second port is another 10 millimeter port
Yes.
from the epigastrium, just below the xiphoid process.
Yes. And below the xiphoid process, and another important relation inside the abdominal cavity. Falciform ligament.
Falciform ligament.
Yes.
Just lateral to the
lateral means
right side of
to the right of
the falciform ligament.
So the second port placement will be in the epigastrium, below the xiphoid, and deep, and see that the port will be going to the right of falciform ligament. So make a 10 millimeter incision, and by twisting movement you insert, and now this port that is going is under vision.
Yes.
Already telescope is in and your camera system is showing you the port entry. Yes. So this second port is under vision. Done. Next is third port entry. That is where
entry is a 5 millimeter port.
5 millimeter port.
It is in the mid clavicular line.
On the right mid clavicular line, below the
just below the
right costal margin. Fine. So again, you made a 5 millimeter incision, and by twisting movement, you go in under vision, and you are in the peritoneal cavity. Yes. The fourth port is.
So the fourth port is along the anterior axillary line.
Yes. At the level of umbilicus. So I made a 5 millimeter incision, and by twisting, go into the port. Yes. So now you have 4 ports. Yes, sir. The umbilical port is called as camera port. Camera port. Yes. The epigastric and the midclavicular port, these two ports are working. Surgeon's right hand working port is the epigastric port. Surgeon left hand working port is the midclavicular port. And trachea port is called as
the
fundus assistant port. So these are the 4 ports you made. Umbilical port is the camera port, epigastric and the midclavicular port is the surgeon's right and left hand working port, and the fundus assistant port. Once you have made these ports, now you change the position of the patient. Yes, sir. Patient goes to reverse central part and right side up. Why?
So that the
you utilize the gravity. Once you do this, the small gut and other stomach all falls away from the area of the surgical site. Okay. So the next step is what?
So the next step is through the fundus assistant.
Describe the heading. The next step is retraction of the and exposure of callus triangle. So how do you achieve that? My heading is retraction and exposure of the callus triangle. How do you do that?
The surgeon through the 10 millimeter port will introduce, from the fundus assistant port, we will introduce one tooth grasper and hold the fundus and retract it towards the diaphragm and towards the right shoulder.
Yes.
For visualization.
So if you say that way, the fundus assistant hold the fundus and push the fundus, the gallbladder, towards the right shoulder. And direction is upward and outward. Upward and outward. And the next retraction is?
The next retraction is from the other 5 millimeter port.
Yes. Surgeon's left hand. He takes a grasper and holds the Hartmann's pouch
and lateral and inferior.
And retract it downward and out. This expresses the callus triangle. Now you have a landmark called as callus triangle or hepatocystic triangle. The boundary is what? Now you have a landmark on retraction. You now expose the hepatocystic triangle of callus. What is the landmark for that?
Sir, the hepatocystic triangle is bounded by the undersurface of the liver.
Yes.
Superiorly, the cystic duct inferiorly, and the common bile duct.
Common bile duct doesn't come.
Sorry.
Common hepatic duct.
Medially. Common hepatic
so once you have achieved this retraction, you expose the hepatocystic triangle, which is bounded above by the inferior surface of the liver, medially by the common hepatic duct, and below by the cystic duct. So that is done. Yes. What is the next step?
So the next step is to
What is the broad heading for the next step?
so dissection
Dissection of
the callus triangle.
no. Dissection of cystic pedicle.
Cystic pedicle. So
What is cystic pedicle?
So cystic pedicle is a two-layer peritoneal layer covering the
Good. So cystic pedicle is once you have exposed this area, you now find a area which is covered by two layers of peritoneum, and in between the two layers, when you have the cystic duct and the cystic artery. So cystic pedicle is a cystic duct and cystic artery invested by two layers of peritoneum. Fine. How do you start now? Now is a dissection of cystic pedicle.
Yes, sir.
How do you start?
We introduce a Maryland retractor through the epigastric port, and then slowly.
You have only 5 or 10 minutes time to describe the whole operative step. So it should be very clear what you are describing. I made a heading of cystic pedicle.
Yes.
So how do you describe this? What do you exactly do?
So we try to achieve the critical view of safety.
That you will achieve by doing what? By dissecting cystic pedicle.
Dissection.
What is the dissection? You said there are two layers of peritoneum.
Yes, sir.
Anterior and posterior layer.
Yes, sir.
So what do you do?
So we will scrape down the.
You have to make a description of what you are trying to do. You said you will introduce a Maryland dissector. Yes. Either a Maryland dissector or people may prefer to use a endo hook. Fine, Maryland dissector is good enough. So use a Maryland dissector attached to the diathermy. You pick up the peritoneum covering the cystic pedicle. You can use short burst of diathermy and then tease the posterior peritoneum. Once you have done the posterior dissection to some extent, then come to the anterior. You tease the anterior peritoneum. Okay, you can use short burst of diathermy. You should be cautious that you should not have thermal injury to the important structure, duodenum or the medial structures. So use short burst of diathermy and tease of the posterior peritoneum, tease of the anterior peritoneum. And then using the Maryland dissector, you go around the cystic duct, go around the cystic artery. Okay? Yes, once you have made this tunnel, what should be done next? You have not achieved critical view of safety. You have teased up the peritoneum, posterior, anterior, and you made a tunnel around the cystic duct and artery. What else needs to be done to achieve critical view of safety?
We need to lift the gallbladder from the cystic plate.
Yes.
1/3 of the gallbladder should be.
So the next part will be once you have this is the peritoneum over the cystic artery and gone around this, you try to lift the lower third of the gallbladder from the cystic plate, both posterior and anterior. Okay. Once you have done this, now you can see that you have achieved a critical view of safety, where you can see the liver and the cystic plate in between the duct and artery, both anterior and posterior. So, dissection of cystic pedicle, achieving critical view of safety. So, these two are done. What is the next step?
After achieving critical view of safety,
the next broad heading should be clipping and division of cystic duct and artery. Yes. Next heading is clipping and division of cystic artery and the cystic duct. So use LT 300 clips to clip the cystic artery. Apply 3 clips there, and then duct 3 clips and divide. Yes. So preferably artery is divided first. Yes. Done? Yes. What is next? Next heading is artery is divided. The next heading is bed. The next heading I'm trying to say is I have divided the operation into salient steps. The next step is dissection of gallbladder from the cystic plate or from the gallbladder bed. How do you do that?
Under controlled traction, we using endosurgical hook, we try to dissect through the vascular plane between the gallbladder and the liver, trying to stay towards on the side of the gallbladder.
What is this? What is this tissue called as on which the gallbladder is resting on the bed? You said already.
The cystic plate.
Cystic plate.
Yes,
so now is the time to dissect the gallbladder from the liver bed.
yes,
and gallbladder lies on a loose areolar tissue plane on the liver bed that is called a cystic plate. And this peritoneum from the gallbladder is reflecting on either side. So using endo, I'll dissect the gallbladder from the liver bed, taking care not to breach the cystic plate. What is the problem if you go deeper into the cystic plate?
So there can be hemorrhage from the liver bed.
One is bleeding and
another is biliary leakage.
So one should not breach the cystic plate. There is chance of bleed or there is chance of biliary leak in the posterior period. So keeping the cystic plate intact, you keep on lifting the gallbladder from the bed. So gallbladder is now lifted. What is the next step? Now gallbladder is taken off from the bed. Cystic duct artery is divided. What is the next step?
So the next step will be extraction of the.
Before extraction, you should do suction and irrigation.
Suction and irrigation.
Because gallbladder can be used as a traction.
Yes, sir.
So before you deliver the gallbladder, you irrigate the area with normal saline.
To look for any bleeding.
Look for any bleed or there is any bleed, you wash it off. If there is a bile leak, you clear that off. So suction and irrigation. And then next step is extraction of the gallbladder. How do you do that?
So it is preferable to extract it through some endo bag.
You describe how are you going to do this. You say I'll put an endo bag through the epigastric port and place the gallbladder into the endo bag.
And then extract it through the epigastric port.
How?
Through using a crocodile.
Yes. So I'll insert an endo bag through the epigastric port, place the gallbladder into the endo bag, and then I'll introduce a crocodile forceps, hold the bag with the gallbladder, and bring it out through the epigastric port, and the port has to be taken out. Once you use a crocodile forceps, as you take it out, the trocar has to be taken out. And then the bag with the specimen is spouting out from the port. If it is a small gallbladder, small stone will come out easily. Otherwise, if there is a stone load, you deliver the gallbladder partially, open it up, taking care not to spill the area, and then take the stones out and the gallbladder out. What next?
So then we will replace the epigastric port.
Next will be reinspection. Once you have taken the gallbladder out, you reintroduce the port, do reinspection. If need be, you re-irrigate and suck. Next may be a step of placement of drain. What's your observation for drain?
Sir, we generally place 18 to we place an 18 to 20 French.
Again, the answer should be drain placement is optional.
Yes.
Okay. I'll inspect. If there is no bleed, no biliary leak, I'll prefer not to put a drain because drain placement is not mandatory nowadays. So I'll do an inspection, do irrigation. If the area is dry, there is no spillage, there is no bleed, I'll not put a drain. Okay, if you want to put a drain, you utilize one of the 5 millimeter port to place a tube drain.
Yes.
Okay.
Yes.
Then
Then we'll place the if we are placing a drain, we'll place it in
now is the time. If you have not put a drain,
Okay.
if you put a drain, you place the drain.
Okay.
Next is you will take the all ports out. What is the
We'll take
sequence? Which port you take last?
the camera port.
Camera port.
Yes.
So now is the time to removal of all the ports.
Yes.
So you take all the ports out under vision. Keep the camera port on. Take the 5 millimeter port, 10 millimeter PST port. Look for any bleed. And then last you take the camera port out. And once you
Slowly
take the camera
visualize
port, you have to empty the peritoneal cavity. Don't take the whole port out with the gas inside. What is the problem? If you take the port out with the gas keeping in inside, what is the problem? You have left behind some amount of gas. What is the problem with the patient? What is this gas?
Carbon dioxide.
Carbon dioxide. So
there will be it will irritate the peritoneum and there will be pain in the
it is more what? Patient may have shoulder pain.
shoulder pain. Yes.
If you leave behind this carbon dioxide, this in the water in the patient can form carbonic acid, and this may irritate the diaphragm and can cause shoulder pain. So before you take the camera port out, you empty the peritoneal cavity, all the gas, and take the last port out of the camera port. Next is closer. How do you do that?
So for the 10 millimeter ports, we generally close the sheet with port closer vinyl.
Yes.
And
so for the 10 millimeter port, this fascial gap should be closed with polyactin suture or PDS suture, and then you close the skin.
Yes.
For 5 millimeter port, you can close the skin straight away.
Yes.
This is the step. You understand?
Yes.
He is not describing one paragraph. If I want to describe any operative step, you describe the operative step into separate headings and then describe what it is doing in each step. This gives a complete description. In gallbladder surgery, there are some important landmarks.
Yes.
These landmarks are important.
Yes.
Where is the Ruvier sulcus?
Ruvier sulcus is between the caudate lobe and the segment 4 lobe.
Segment 4 is not there. Segment 4 is in the left of gallbladder bed.
Yes,
if you say Ruvier sulcus, the caudate lobe and the
right lobe.
Right lobe. Yes.
Sorry,
not
right lobe and the caudate.
Yes. What is the importance of Ruvier sulcus? What lies deep to Ruvier sulcus?
Right.
Come to that. What is the importance of Ruvier sulcus, and what lies deep to Ruvier sulcus?
Right deep.
Right.
Yes, sir.
Yes, sir.
There is the right deep.
Right posterior. Right portal structure has got a sectoral branches.
Yes.
Okay. The posterior sectoral branches lies on the
posterior
sulcus. Okay. This is the important landmark, because from this Ruvier sulcus you can draw a line. What is that line called as R4U line? What is that line?
It is the line that demarcates the.
Why do you draw? How do you draw this line?
So it extends from the Ruvier sulcus to the umbilical fissure.
Yes. Where is the umbilical fissure?
Umbilical fissure is between second and third lobe, and the second and third segment, and
no.
It's at the place from where the falciparum.
So where the falciparum lies? Falciparum doesn't lie in second and third.
Sorry. The
Falcion ligament
caudate and the
is dividing the left lobe
yes, sir.
between the 3 and 4.
3 and
4 is part of left lobe.
left.
Okay.
Yes.
And as you see the falcion ligament lying there, the deeper area where the ligament of teres is going into the liver, that is the point which is the umbilical fissure.
Yes.
So this is R4U line.
R4U.
This line is important. Why?
Because any dissection
should be lying
above the R4U line.
Above and lateral to this line. You should not go middle to this line. Sometimes this revered sulcus may be indistinct and it's a difficult gallbladder. What other landmark you can use?
The segment 4 of liver is itself a landmark.
What is the segment 4? Segment 4 is a broad area. What you draw in the segment 4 to be safe.
So the base of the segment 4.
Yes, base is a wide area. Base is a wide area.
Yes, sir.
So why do you draw this line? Described as D line.
D line.
What is that line? Segment 4 has got a dorsal border, has got a ventral border. So this dorsal border is where the falcion ligament is attaching. So draw a line from this and go up to the ventral border of the segment 4. This is a D line. So if you're in difficulty and you want to bail out from the difficulty, you find this line and keep your dissection superior to this. Don't go middle to that. If you're doing a partial cholecystectomy, don't go below that line. Because deep to that line is lying the right portal pedicle. Right portal pedicle is lying deep to that. Okay, so these are the important landmarks one should keep in mind while doing this. So, Dr. Ronit has asked you a question. You said you will achieve critical view of safety. Yes, what do you mean by critical view of safety?
Sir, critical view of safety is while dissecting when 1/3 of the cystic plate is exposed.
Yes. The first criteria to achieve your safety is you have to tease of the anterior and posterior peritoneum of the cystic pedicle. And you have to make a tunnel around the cystic duct and cystic artery. Yes, you have to make a dissection of the distal third of the gallbladder to expose the distal third of the cystic plate. Once you have done this, what is the anterior view? Anterior view is if you pull the Hartmann's pouch down and out, you can see the liver in between the cystic duct and the cystic artery. Number one. If you pull this Hartmann's pouch upward, retard it upward, from posterior, you can see the bare liver. So that is achieving the critical view of safety, both anterior view and the posterior view. What is time out in critical view of safety? What is time out? Is it, time out in surgical safety checklist? There is a concept of time out in lap cholecystectomy. When you do time out. This is now a standard protocol for doing lap cholecystectomy. You follow time out. When you follow time out. Time out is before you apply clipping. Before you apply clip, you redemonstrate the cystic duct, cystic artery. You redemonstrate the walls of cystic plate. Show it to your assistant. Show it to the anesthetist. Then only you are allowed to clip. This is critical view of safety, and you have to demonstrate this safety to your team members. And people are satisfied. Yes, now you go ahead and clip. That is one of the safety mechanism to avoid biliovascular injury. Okay. Okay. 2 minutes. Exam is for 10 minutes. What are the complications of lap cholecystectomy? What are the complications of lap cholecystectomy? How do you describe the complications of lap cholecystectomy?
So there can be biliary leakage.
Why do you jump to biliary leak? I asked you to give me a outline to describe the complications of lap cholecystectomy. I will start with anesthetic complications. So there are some general complications. There are some complications pertaining to specific to lap cholecystectomy. General complications are general complications, which is applicable for any major surgery. Patient is undergoing anesthesia, undergoing major surgery. Patient may have pulmonary complications. Patient may have other complications like DVT. Patient may have lung atelectasis. Patient may have cardiac complications. That is one. Second is complications to specific to lap cholecystectomy. In lap cholecystectomy complications, you have to describe complication pertaining to access. While you are taking access to the peritoneal cavity, either by closed or by open, there are some specific complications.
Port side bleeding.
Port side bleeding. What else?
Then
all possible complications can happen. Because we have checked, we have aspirated, you have injected saline, you have looked for what. So, what are the access complications?
Sir, any bowel injury.
Bowel injury.
Making the.
Just give me headings. One is bowel injury. Second,
port side bleeding. Blood vessel, vascular injury.
Vascular injury. Next is
any organ, solid organ injury like bladder injury.
Bladder. So bladder is not a solid organ.
Sorry, I mean
bladder injury. These are important injuries. While you are doing a neoperitoneum, you can injure the bowel, you can injure bladder, you can have vascular injury. Okay? So these are access complications. There are some complications which can happen because of pneumo. You are doing neoperitoneum using carbon dioxide. What complications can happen because of that? One is rapid insufflation can cause reduction of cardiac output, patient may have cardiac arrest. What are the ill effects of carbon dioxide itself? Ill effects of carbon dioxide.
It can cause acidosis.
Yes. It can cause acidosis. What else? Carbon dioxide is a highly diffusible gas. Once you use carbon dioxide in the peritoneal cavity, these carbon dioxide get absorbed. And you will find that anesthesia often makes hyperventilation. This absorbed carbon dioxide goes to the lung bed and that has to be expelled. So you have to hyperventilate this patient. Hypercarbia has number of ill effects on cardiac system. What? Initially, when the lap chole started, people used to give an antiarrhythmic drug at the beginning itself because it can cause different types of arrhythmias. It can cause ectopic. It can cause atrial fibrillation. It can cause other serious arrhythmias and even cardiac arrest. So this carbon dioxide can have some ill effect. Why carbon dioxide is preferred over other gas in neoperitoneum? Why is the carbon dioxide preferred gas for laparoscopic procedure? People earlier in gynecology used to use oxygen. They used to use nitrous. They used to use air.
So oxygen is highly
oxygen is inflammable.
So we cannot use
oxygen supports combustion. Oxygen itself is not inflammable. It supports combustion. That means if you use a diathermy, it will help in this combustion. As such, oxygen is not a combustible gas. They used to use nitrous. People used to use air. Gynecologists who are doing their ligation, they use all sorts of gas.
So nitrous oxide is.
What is the advantage of carbon dioxide over the other gases?
So it is easily diffusible.
Diffusible. That
Yes.
means one of the complication of this insufflation is embolism. So if you use air and then there is a venous opening, this air goes into this circulation, it can cause air embolism. Air embolism can kill. Air embolism can kill a patient on table. But if the carbon dioxide gas entered into the circulation, this gas become diffusible in the blood. Immediately it is converted to carbonic acid. And this carbonic acid coming to the lung splits into water and carbon dioxide. And this carbon dioxide you can wash off. That is the advantage. Second is carbon dioxide is non-combustible and does not support combustion. So if you need to use diathermy, you can safely use. And carbon dioxide is cheap. But ill effect of carbon dioxide is it can cause acidosis, it can cause cardiac arrhythmias. Okay. Other complications. So you divide the complications. General complications, complications pertaining to special lab cholecystectomy. One in that is access complications and complications pertaining to the lab cholecystectomy. So lab cholecystectomy complications are bleeding. Then biliary injuries. And again, the biliary injury is one big field. There are different types of biliary injury. If you go by classification, there are different classifications of biliary injuries. It can be a accessory duct leak. It can be cystitis stump blowout. It can be a lateral injury to the bile duct. It can be complete cut off of the bile duct. Okay. It can be a combined biliovascular injury. It can be associated thermal injury to the gut. You can injure the duodenum. You can while using diathermy, you can even injure small gut. So gut injury, thermal injuries. ठीक है चलो 9 o'clock. Thank you. Any question? Any question from anyone?
Sir, one question, sir.
Yes.
So, after entering, if you find it to be a difficult callots and you cannot proceed for on any kind of achieving the critical view of safety, so what are the bailout procedures?
You entered into the abdomen for doing lab cholecystectomy, but you feel that it's a difficult situation. It is difficult callots, difficult dissection. What are the bailout procedures?
So first is to call for one we can abort.
Yes, that is most
we can
important.
abort.
If you have not done anything which is not going back is possible, first thing is to abort.
First,
You can abort a procedure, but you should not make a hole in the gallbladder and then abort. No. So if you feel so difficult, one is abort. Second
is trying to do fundus first.
Fundus first is a very difficult decision. So you tell us the steps. Next should not be fundus first. Abort. Next is
conversion into open.
Yes.
Conversion into open
Say go step by step. One is abort. Second is if you are not proceeding, you open up. You should be more comfortable while opening up and doing a open cholecystectomy. Next. You can always call for help at any stage. You understand?
Yes, sir.
You are trying to do fundus, you do partial ectomy, you do injury, and then call somebody is not wise decision. So if in difficulty, you call for help at the beginning. Take a second opinion. So call for help. Next is what is the problem with the fundus first technique? Fundus first technique seems to be a safe technique, but fundus first technique may associate with serious injuries. What is the problem in fundus first technique? If you have not taken the vessel first, you start doing fundus first, there is chance of bleed, number one. And if you are not following these important landmarks, that means this R4U line or a segment 4 line, as you dissect towards the Hartmann's pouch, this area may get tented and you can land up with serious injuries. So fundus first technique is also important, but you should be very cautious. And another bailout technique is doing a partial cholecystectomy. Partial. Okay. And as I said, while doing partial cholecystectomy, you should be following these landmarks. You should not go beyond the rubeoid sulcus point so that you are not in the bile duct. If that is not distinct, you can use segment 4 line. And while doing partial cholecystectomy, you should be ensure that you don't leave a stone in the stump of the gallbladder. You open up the gallbladder, clear up the stone, and then you just close the remaining stump. So these are different bailout. Ronit, you want to add something?
No, sir. In partial subtotal cholecystectomy, there are two types of subtotal cholecystectomy. One is fenestrating and one is reconstituting. Fenestrating means you just suture it up by a purse-string suture, and in reconstituting, it is like a suturing the stump only. That's all, sir.
And in some situations, in very difficult situation, often the cystic duct is blocked. And if the difficulty be, you may avoid suturing. You can put a drain and come out. Most of the time, the cystic duct is already blocked. So if the difficulty is so much, you can avoid suturing also. Okay.
Okay, sir. Okay, sir.
Thank you. Thank you all.
Thank you, sir.
Thank you.